Hello, everybody. Welcome again to another edition of the MCHD Paramedic Podcast. This is Dr. Casey Patrick, and today we have a special guest from the field here at MCHD. One of our in-charge paramedics, Jason Jones, is joining us. Thanks, Jason.
Thank you. Sometimes
we describe 1 in a million cases, once in a career cases. We talk about that sometimes when we do a surgical airway or maybe an organophosphate poisoning, something interesting and rare. Today we really have, in all actuality, a once in a career, I believe, case. Maybe not 1 in a million, but pretty darn close. And before we get into the details and spoil everything, Jason, start with an intro. This is your first time on the podcast. Tell the listeners about your role here at MCHD and how long you've been here. Just a little brief intro.
Okay. I'm an in-charge paramedic here at MCHD. I've been a paramedic for going on 22 years and been with MCHD for 5.
Excellent. So walk us through the initial portion of this call. Don't give away the punchline, and I believe I can predict the listeners may not grasp the significance of the case with just the CAD notes that you had. So talk through the initial pieces, and we'll get to the point where you realize something was up.
Okay. We were dispatched to a chest pain in our district at one of the local businesses. And even en route to the call, reading the notes, it was fairly clear that I even got a text message from one of our district chiefs that says, that sounds like a STEMI. The call note said it was a male that was having chest pain. He was clammy, he was short of breath, and he had pain radiating down his arm, all of the classic MI type symptoms. And when we pulled up on scene, just kind of doing the windshield size up through the front windshield, you could tell immediately as we pulled up, he was sitting outside on a bench, that the patient was sick.
And you said pain radiating down his arms, plural, correct?
Yes, that's correct. Initially, the first call note said it was radiating down his arm, and at contact, he said the pain was down both arms, both his right and left arm.
I thought that was a pretty interesting just tidbit to add in the discussion. We always think about the left arm being predictive of acute ischemia, but both arms is actually more predictive when
Correct.
You look at positive likelihood ratios and those sort of things. So pain down both arms, bad sign, clammy, diaphoretic, middle-aged male, had some cardiac risk factors. So your CAD note district chief conversation, your initial windshield size up, these were all accurate. So when you approached him as if he was going to be a STEMI, I assume. We've got scene time, we've got hospital notification, we've got all those things in our brain. What order did you go in?
The initial thing was to make contact, and as soon as I touched his wrist, I realized how clammy and cold he was, and was like, okay, yeah, this is more than just presentation, more than just the eye test, that he is actually acutely ill. And the next step was obtain vital signs and get an EKG as quickly as possible, which turned out to be a little more difficult given his diaphoresis.
So you're fighting with diaphoresis, you're trying to dry him off, you finally get your leads in place. Then what happens?
The initial 12 lead, as we're taking the 12 lead, the patient's wife walks up, and she starts talking to us about what's going on, and she's like, hey, what's going on? And the initial 12 lead is kind of difficult to obtain because the patient's unable to sit still because he's in so much pain. But the first 12 lead that prints out says arm lead reversal.
And then the patient gave you the kicker. He
Right.
told you, correct?
Yeah, he told me exactly why the 12 lead said that. He was having difficulty talking just due to his just severe distress, and his wife said he had situs inversus.
So situs inversus, for the listeners out there, go over it. Some of you all probably have heard of situs inversus. Situs inversus occurs in about 1 in 10,000 folks. Some sources even cite higher numbers, upwards to 1 in 100,000. And this gentleman had situs inversus totalis, which involves both dextrocardia. The heart normally lies on the left side of our thorax. In a situs inversus totalis patient, it's on the right. But the abdominal cavity and the contents of the abdominal cavity are also a mirror image as well. We see dextrocardia not terribly infrequently. It's much more common than situs inversus totalis. But when we think about EKG leads and how we're going to capture our ST elevation MI, it becomes a little more difficult. How long have we known about situs inversus? It was first described in 1643. And doing a little situs inversus research and dive into this, we've known about it for a long time. It was first seen on X-ray dextrocardia in 1887, which honestly I probably would have thought that would have been a little bit later. What happened then? So now you've got, okay, this is showing limb lead reversal, and I'm looking at it, and everything is correct. Patient's telling you, hey, I've got situs inversus, or his significant other, his wife was. So what do you do?
I asked the patient, I said, is everything flipped? And his wife said, yes, his heart, lungs, everything in his abdomen is flipped. He has complete situs inversus. I said, okay, well, let's flip the leads. So we flipped both the limb leads and the precordial leads to the right side of the patient's chest, and which took some time given that he was diaphoretic. We'd already used a bunch of our benzoin with skin cramp, so I had to go send somebody to the truck to get more. And they came back with 2 more packages of it to get the right side of his chest prepped and obtain the EKG on the right side of his chest.
Which demonstrated, and we'll link his tracings in the show notes, a fairly obvious anteroseptal MI, if I remember correct.
Yep.
You saw ST elevations in leads.
I believe it was V2 through V5, which was completely concerning for acute coronary syndrome and an occlusion of the, would be the LAD, but given his situs inversus diagnosis, I was just going that he's having an MI on the front of his heart.
Yeah, I don't know if that's the right anterior descending or just the anterior descending. I've struggled with what we're going to call it on the podcast. I'm not 100% sure, but the big vessel running down the anterior portion of the heart that happened to be on the right side of this gentleman's chest appeared to have acute MI, occlusion MI, very clearly on the EKG. So our scene time, despite some of these hurdles, his diaphoresis, his uncommon diagnosis, we were able to alert the incoming hospital. Cath lab was activated. What happened when you arrived at the ED? Because this is not something that I've ever seen in my emergency department practice, and I would venture to bet that not a lot of folks out there have, and we'll talk a little bit about that as we go through. So how did you give changeover, and how was that received?
So when I first sent the notification, I was still in the process of attaching the 12 lead because you have to have the Wi-Fi to send it, and I sent the Pulsera from the patient's side, and we have to be close to the ambulance to be able to transmit the 12 lead. So I just said STEMI, patient has situs inversus and has an anterior MI, and transmitted the 12 lead once we got in the ambulance, and they didn't ask many questions, which typically they will. They were like asking us, does the patient have cardiac history? Does the patient have chest pain? In this one, they didn't ask any questions. And we get to the room, and I'm giving hand over to the ED physician, and he's like kind of skeptical at first. He was like, okay, the patient has situs inversus. So yeah, everything's on the right. And even the EKG tech went to apply the leads to the left side of the patient's chest. And he's like, no, those need to go on the right. And they applied the leads to the right side, obtained their EKG, and he'd already sent the EKG to the cardiologist, and the cardiologist had said he was on his way down. But once the ED physician got his EKG, the patient was quick to the cath lab. They gave him some additional fentanyl for pain control that we had started in during the trip. We'd given him the aspirin and fentanyl. And the hospital staff had followed up with additional fentanyl and sent the patient onto the cath lab.
I would assume probably got some heparin in there, usually a 5,000 bolus hits.
Yeah, I believe so.
Additional pain meds, plus or minus. In this situation, I don't believe there was any nitro involved on our end. I think his pressures were good. He was GCS of 15 throughout. If I remember right, after talking to the patient, Jason and I both had a chance to meet this patient after the fact. So if there's any HIPAA concerns out there, we've gotten permission for this one.
Correct.
He felt quite a bit better en route to the hospital, but still was very uncomfortable, still very clearly with acute ischemia. There was no reperfusion during this hospital ride. He was still very clearly occluded based on just his pain, correct?
Yeah, his pain was 10 out of 10 initially, and he said when you say 10 out of 10, he goes, I don't think people understand how, when I say 10 out of 10, how bad that was. He was his pain I couldn't imagine. He said it hurt so bad that he was like he couldn't get away from it, is how he described it. There's also the link. I don't know if they can put the link to the the reunion or the case presentation. We can put
absolutely.
that in the show notes.
Yeah,
that people can watch the patients. He can kind of give his side of the story. In our, I don't remember what we called it.
We had a SAVE reunion with this patient. It wasn't really a cardiac arrest, more of I guess an impact award, just based on the obscurity and the rare nature of this case. And this gentleman was just very giving of his time and was very effusive in his praise of Jason and the crew and the ED staff and really everyone involved, because when they got to the cath lab, they found a 99% anterior occlusion. I guess that would be a right anterior descending occlusion.
Correct. And
that fit the V2 through V5 ST elevation that we saw on his EKG. It just wasn't on the left side of his chest. It was on the right. The cardiologist had a very difficult time, to the point of being unable to access the right coronary artery, or what would be the right coronary artery in a normal patient, because of the angle of the takeoff and the mirror directionality. The equipment's not built to access a right-sided heart. So what happened during the cath? Well, he was quite uncomfortable throughout. Jason, you were there?
Yeah, we accompanied to the cath lab.
So explain to the listeners kind of how that happened.
So he went into the cath lab, and even the cardiologist, he was still kind of shocked at the presentation. He was like, "Man, this is like a 1 in a million kind of case." He goes, I called my colleagues on the way down here, and none of them had ever heard of it or dealt with it, or had heard of STEMI in the instance of situs inversus. Not so much the situs inversus; they had seen that, but they'd never seen a situs inversus patient having a STEMI. And he was like, "This is a 1 in a million case," and was telling the patient kind of what he was doing. And once they found the occlusion, and had placed the stent and opened up the occlusion, the patient was immediately pain-free. He was like, "Oh, wow, I feel so much better." And it was instant improvement. He stopped sweating. His chest pain was down to a 0. He was like, I feel great.
So from a clinical standpoint, when we think about this has implications for everything that we do in emergency medicine and EMS care. If you have an incomplete picture, and the cardiologist had a true incomplete picture because he could only access the anterior descending. He could not access what would be the RCA in the
Correct.
normal left-sided heart because of the directionality. Well, what did he do? He used his clinical acumen and said, okay, the EKG suggests an anterior descending lesion. I opened said anterior descending lesion and the patient felt better. Could there have been a lesion elsewhere? I mean, people have 2-3 vessel disease not infrequently, but putting together the fact that, hey, I'm roadblocked by the anatomical abnormalities that we've got here, buffered with, okay, I opened up the anterior descending and now the patient feels better. I got to believe that's where it's at. I got to believe that I've fixed him. And there was really nothing else that could be done at that point. But because of that drastic relief and that just immediate stabilization of the patient, the cardiologist elected to really abort at that point and say, you know what, we'll deal with the other side of the heart sometime later. And they actually scheduled him for coronary CT imaging to try to visualize and calcium score the other side to look for further occlusion. And thankfully for the patient, that was the only significant lesion. He was functional and back to the work by the time we met him at the Impact reunion just a few weeks later, and was doing very, very well. So just an amazing case. Really, truly, if you think about situs inversus being somewhere between 1 in 10,000 and 1 in 100,000, what's the odds of that patient having an ST elevation MI, calling 911 and seeing a pre-hospital EMS presentation of occlusion MI in a situs patient? I think 1 in a million is probably there. It's no one that we've talked to in the cardiology world, in the EMS world, literature search wise, there's no case reports of this happening, which is a pretty cool conversation to have. It has to be a pretty cool feather in your cap, Jason.
Yeah, it definitely was.
It's just amazing. I do want to make one final point about this case. We've thought about it a lot. Jason and I have chatted about it several times. That is really not related to the cardiology side. It's not related to coronary anatomy or EKG physiology or electrophysiology or occlusion MI or any of those sort of things. This patient was anxious, was obviously in distress, was diaphoretic, wasn't giving you a clear story.
Right.
The family was a nervous wreck. Their loved one was having a heart attack. Those sentences and that communication was not clear. It was jumbled. You could have, definitely called that a high stress situation, and you were getting the patient's jumbled communication, the wife's frantic communication, and they told you some what seemingly could have been bizarre details.
Correct.
But that bizarre detail was the key factor in the case. And we get bizarre details and bizarre stories, and I'm going to tell you one more thing, and this may not be related, but let me give you this or that or the other. In that stressful, clearly critically ill, diaphoretic situation, time sensitive, trying to get off scene, trying to get our EKG, trying to get his sweat dried off, you were able to listen, move things around, go back to the truck, get more benzoin. How do we balance this case where that bizarre fact actually was the key with all of that noise that we get? Because I know in my practice, patients tell me things all the time that are just blatantly incorrect, not out of any other reason than knowing your medical history and medical knowledge is confusing. You try to read your discharge summary from the hospital and figure out what happened. It can be pretty rough. How did you filter it in this case? And I don't want to say believe, because I think we always should believe our patients up front. But how do you sift through that? How did you keep your balance, keep your focus?
The big thing was that it correlated clinically with what I was seeing. I had the arm lead reversal on the initial 12 lead, and they told me that the patient had situs inversus totalis, and I was like, well, that fits what I'm seeing, considering that the leads are placed appropriately, and I'm seeing an arm lead reversal, and the EKG appears to have arm lead reversal. The axis was strange, and once they mentioned the situs inversus, I was like, okay, that correlates. So not only did we take into account what the patient and the family had said, we altered our assessment and treatment plan to coincide with what they had told us.
And then you saw objective evidence that
correct.
The second EKG, no limb lead reversal, looked more like what you would expect an EKG to look like, axis back to normal.
It looked like a normal 12 lead, a left-sided heart 12 lead.
And I believe that that's really a great message, in that just because families, patients, loved ones give us tidbits of information, we always have to filter those. And sometimes the request or the information may be entirely extraneous, not useful. No, we can't, start the insulin drip in the ambulance. People ask us to do things and tell us things that are, frankly impossible. But it doesn't mean that we have to push back against all those. And when we have objective findings that, hey, maybe this could be helpful, it hurt you, 3-4 minutes to probably, I'm going to have to reassess here. Maybe we do need to flip all these leads. Okay, it's worth it. And I believe in this situation, because your existing objectivity was confusing and, hey, maybe this is the key to the puzzle, you acted on it. And I believe that that's something we should all, as providers, both EMS, emergency department, sometimes that crazy sounding last sentence that the patient sneaks in there may be the key to the entire diagnosis, maybe the key to the next lab that you need to order. Maybe that's a vital piece of information that you need to provide the emergency physician in handoff. Who knows? But I'm glad that you were prompt in your recognition of the critical illness of this patient, but also at the same time with your ears open to say, wait a minute, this is something I've never seen before, but I'm hearing you, and let's flip it. And it did prolong the scene time by a couple minutes, but it reduced the cath lab time by a multitude greater, because that could have been a really difficult one to sort out had you waited to get to the hospital or not acted on the activation because, this limb lead's reversed and I'm not sure about this EKG, let's just go. Sorting it out there on scene really greased the skids down the line. And, a big 99% anterior descending lesion is not something to be trifled with. That's a big deal, and that extra 10, 15, 20 minutes could have been the difference in VTVF and a stent and a healthy heart now. So excellent work. Anything you want to add before we wrap up?
No, I think that that about covers it.
Well, we'll link some situs inversus information, the 12 lead. We've got
the impact reunion.
We've got some cath fluoro even. This patient's been very gracious with allowing us to tell his story to try to maybe help somebody else out there. And the listeners, you may get this once in your career. And if you listen to that patient, you reverse those leads. That anterior descending ST elevation MI looks pretty similar whether it's on the right or the left. So as always, please follow us wherever you listen. Check us out on YouTube. Leave us a like, leave us a review. If you have suggestions or ideas, hit us up, podcast@mchd-tx.org. Thanks for listening. We'll be back again with a new episode soon.